So the dentist who speak, this method is best method, it's not scientific based. The most studied technique was GBR among these options. Also, AO consensus on 2007 reported the number of studies by grafting technique. GBR was the most studied grafting technique except sinus bone graft. So, it is reasonable that we choose GBR technique as the first option for hard tissue augmentation. Let's look at GBR with bone graft procedure in detail. In EAO consensus on 2009, clinical outcomes of GBR is well summarized into 7 conclusions. Therefore, I will explain GBR procedures based on this consensus. The first conclusion is that there is not enough evidence showing the correlation with long-term survival rate of implants, whether GBR is performed to cover bone defects or not. Does it mean that GBR is not necessary for long-term survival rate implants? To know the effect of covering bone defects by GBR procedure on long-term survival rate of implants, we have to conduct clinical research designed as follows. Here are narrow ridges. Implants are placed on narrow ridge, then implant surface will be exposed. In one group, exposed implants are remained without GBR. And the other group, exposed surface are covered with GBR procedure. And then follow up and compare the survival rate of implants between 2 groups for long-term period. However, this research is practically impossible because ethically we cannot remain the exposed implant surface during the surgery. This consensus said that. We don't know. Fortunately, there are studies that show bone regeneration by GBR is meaningful for long-term period. In these studies, the survival rate of implants placed on narrow ridge with GBR procedure for covering exposed implant surface is compared with implants on wide enough ridge with no need to do GBR procedure. The result is similar. These studies show that GBR is meaningful for long-term survival rate of implants. Among 7 conclusions, from 2nd to 5th conclusions deal with barrier membrane. And 6th conclusion deals with bone graft materials. And 7th conclusion deals with another reason why we should perform GBR procedure on bone defect from an aesthetic point of view. If dehiscence defect is remained without bone regeneration by GBR, soft tissue recession can easily occur, and also soft tissue can be darkened to gray color around implants. Soft tissue recession and gray colored gingiva become especially big problems in anterior region. For now, let's see a case related 7th conclusion. This patient was referred to me to solve the problem peri-implant tissue. You can see the gray color of gingiva at the position of implant. When I reflected the flap, there was a dehiscence defect on the labial side. The other dentist placed the implant immediately after extraction. After placing the implant, the labial bone was resolved. Gray color of implant appeared to visible through thin gingiva. I performed CT graft to mask the gray color of the exposed implant. As you can see, the gray color was disappeared after CT graft. However, gingival recession was occurred after prosthesis delivery. If the dehiscence defect is not corrected, we cannot resolve the problem of the gray gingival color or gingival recession. For these reasons, the dehiscence defect should be corrected by bone regeneration, especially on the anterior region. I mentioned earlier 4 out of 7 conclusions are related barrier membrane. Second conclusion is that both resorbable and non-resorbable membranes show the ability to promote bone coverage of exposed implant surface. And third conclusion, non-resorbable membranes has a higher complication. Non-resorbable is 20%, resorbable membrane is 5%. So non-resorbable has 4 times higher complication rate. Based on second and third conclusions, of course, we would choose resorbable membrane over non-resorbable membrane because of low complication rate of resorbable membrane. However, we have to consider fourth conclusion. It says that non-resorbable membrane show the ability to promote bone regeneration on a dehiscence implant surface, also without bone graft. It can be interpreted that non-resorbable membrane has space-maintaining ability for itself. Therefore, non-resorbable membrane is sometimes necessary for cases that space maintaining is difficult through resorbable membrane. It means the necessity of non-resorbable membrane in some cases. Also, many studies show that space maintaining is important for bone regeneration. Polymany's study on 2004 is one of these studies. This study showed that space provision has a significant effect on bone regeneration following GTR. For this reason, there are indications that we had better use non-resorbable membrane, although it has more complication. I want to show cases I use non-resorbable membrane for GBR, and through these cases, we can see the space-maintaining ability of non-resorbable membrane. Its first case. This patient was referred to me for ridge augmentation on lower right edentulous ridge. As you see, this teeth was hopeless. This intraoral photo and panorama X-ray after extraction. You can see the huge ridge defect. Through the CT scan, we can see the state of the edentulous ridge. The lingual bone was well maintained, but buccal bone was severely lost. On this ridge, it was difficult to place implants at the proper position and angulation. So I planned ridge augmentation first by GBL with bone graft and implant placement later, namely staged approach. After flap reflection, I could see large bone defect on the buccal side. According to Carlo Tinti's defect classification, as I mentioned before, this is a horizontal ridge deficiency. I drilled hole for blood supply to bone graft site. We call this procedure as decortication. I grafted mixture of allogenic and alloplastic bone. This patient has a liver disease, so he didn't want to harvest the autogenous bone. But I think that's not a problem. And I covered bone graft site with titanium reinforced Gore-Tex membrane, which is a kind of non-resorbable membrane, and I sutured. I waited for over 6 months because bone defect size was huge and I didn't use autogenous bone. When I opened the flap, the defect was disappeared and the ridge was wide enough to place implants. Despite over 6 months has passed, titanium reinforced membrane maintained the original shape when I was applied. And the bone was filled fully regenerated under the space by the membrane, under the membrane. These are panorama X-ray during treatment, after extraction, right after bone graft and GBL, during healing, right after implant placement, crown setting, and 2 years follow-up. These CT scans were taken before ridge augmentation. These were taken right before implant placement. We can see the titanium reinforced membrane, which is well maintained, the shape. The regenerated bone under the membrane. These were taken 2 years after loading. The regenerated bone was well maintained and bearing the load. Let's see one more case that I used non-resorbable membrane. This is the upper jaw case. The number 16 and 17 were extracted due to severe alveolar bone loss. This panorama was taken 2 months after extraction. As you see, extraction site has a huge bone defect. In also intraoral photo, we can see vertically resorbed ridge. In this case, I used titanium mesh, which is a kind of non-resorbable membrane. After flap reflection, we can see the huge defect as predicted from the X-ray. I grafted the mixture of the allogenic bone and alloplastic bone. The grafted bone was covered with titanium mesh, and I sutured. Healing is uneventful. I placed implants 7 months after GBL. When I opened the flap, the titanium mesh was well maintained with the original shape. When I removed the titanium mesh, I could see the regenerated bone according to the shape of titanium mesh. The ridge crest could be augmented wide enough to place implants due to the space maintaining ability of titanium mesh. These 3 photos were taken after implant crown delivery. And this photo is the initial photo, which was taken right before GBL. Comparing with the initial photo and the final photo, we can see that alveolar ridge was well augmented vertically.